Over to Dr. Narendran, sir, for the first case presentation.
Good evening. And more to the next slide. So this patient is a 56-year female, diagnosed with stage 3 CA ovary. We have started initially. Can you move to the next slide? Next slide. Next slide. Okay. So this patient, initially the CA-125 was very high, and she had ascites stage 3. We started on neoadjuvant chemotherapy, Pacli Carbo. After one cycle of chemotherapy, patient had a good clinical and biochemical marker response. So she has continued on chemotherapy. After the 3 cycles of chemotherapy, again the CA-125 increased, but a patient clinically had a good response. So we went ahead with the surgery. Surgery also, compared to the initial diagnostic laparoscopy, the PCA score was improved. So surgery was done. After surgery, we have sent a surgical specimen for HRD, and we have completed the remaining 3 cycles of chemotherapy. So can you go to the HRD report? So this HRD report shows that tumor BRCA1 is positive, which is pathogenic, but the genomic aberration score was low, only 5. Because of the BRCA positive, the HRD is they reported as positive here. So coming to the clinical response, there was a differential response, like the biochemical markers initially came down and then increased. And other than this genomic aberration score is very low in spite of BRCA is positive. So can you come back to the questions? Uh,
Narendran,
so uh,
before question, what is the pathology report of the cytotic? Like how much is
uh,
residue that was left?
so it is like stage 3C only, sir.
Okay. How was the
Uh,
response pathology based on the pathologist? How was the response to the platinum? Was it in sync with HRD positive? That's what I want to know. What was the pathologist feel when he's
yeah, pathology wise, if you see the this one initial PCA score was around 25, sir. But
okay?
when they opened, it was like less than 10. So
Okay.
clinically, it correlated with a good response. Pathologically, it's still stage 3 only. That is,
Okay.
so still there are deposits are there, which fits into stage 3C.
But not the typical response you see in
Not
HRD
typical
positive.
typical BRCA1 positive, we
Typical.
see a very
And
good response.
how
So that is
significant is
not
the
there.
rise? You just mentioned rise of CA125 after
So
3 cycles.
initially it was like it fall down from 1,000 to came down to within a one cycle it came to around 300, sir. So
Okay.
then before third cycle, to surprise, it is again around 1,000 range.
Okay. Okay. Okay.
So so that was a differential response. We checked it twice. Again, it was both the values were C75, similar value only around 1,000 something.
Okay.
So,
Okay.
but clinically, when they went inside the surgery, when they went inside, the PCA score compared to before was less.
Okay.
So, so that is what.
Was bevacizumab also added along with
No,
platinum in this case?
no, I thought of adding because of the poor biochemical marker. We thought if again the PCA is very high, we will add on bevacizumab. But again, the PCA is low, so they went ahead with surgery. So bevacizumab
Okay.
was not added.
Okay. Okay. Proceed with the
Uh,
questions.
So this patient, somehow there is not a typical response with, even though the BRCA1 is positive. So whether it's whether we this HRD is done from the interval cytoreduction tumor. So ideally, what they recommend is to do from the initial biopsy. So whether there is a heterogeneous tumor is there, which with some component of BRCA, some component which is non-BRCA, which is not responded, and whether it's a BRCA reversion heterogeneity here. So just anyway, I'm starting on olaparib, but considering this differential response, what could be the reason here? And prognosis, it's not like typical BRCA1, so just wanted to discuss here.
Thank you, Arun. Okay, my thoughts before others start. I'll just start so that it will give some time for others to speak. One is it's not behaving the typical HRD positive because the way CA125 is rising, and even during the cytoreductive surgery, the way you are describing it doesn't look like a typical BRCA positive or HRD positive case. That is point number one. But still, you know that even if HRD score, genomic aberration score is low, if BRCA is positive, it should be taken as HRD positive based on the molecular test. So here one is whether we can send up if upfront biopsy is done, can we send HRD in that? That was the first thought for me to make sure to just understand. Second thing is have we sent for germline testing of BRCA for this particular patient?
We have sent, so it's awaited. We have sent
Okay,
for
that
that.
is the second.
Mm.
Okay, that is the second
Mm.
thought that came to me. Third is tumor heterogeneity, BRCA reversal all happens very late after exposing the patients multiple lines of
All
chemotherapy. Yes, I think Arun Kumar has posted one case long time back of BRCA, interesting case of BRCA reversion in a breast cancer case, but not so early having a BRCA reversion. So that is quite early for me to think of that. Fourth is yes, olaparib probably add bevacizumab plus olaparib may be adding both may be a better choice in this case. These were my thoughts. Probably we'll see others what they are thinking.
Can we go to that report of HRD slide? That slide. Yeah.
This VAF is 46%. That is quite high. 46%. I think any other molecular person like Silambaresan is there. I think probably we can take his thoughts.
Yes, sir. So basically, it's a BRCA one, but as I heard from you, Dr. Narendra, the patients are sensitive to platinum-based therapy or not?
When we see platinum-based sensitivity, it's not a typical BRCA. If it is BRCA positive, we see sometimes we see so good response that even CR will be there. Sometimes some stage 3C, it will be like stage 1, only so much residue will be there. But here it's somehow it's a patient responded, but to say BRCA positive, so much response we didn't get.
Okay. So one experience I can share because of based on this report, if you are looking for, as you rightly said, BRCA1 platinum positive, platinum sensitivity should be there, but as we expected, it is not there. Usually, the serous carcinoma they tended to have along with BRCA1 mutation or any HRD kind of the DNA repair mutation. If any additional mutations is there, sometimes there will be resistance. So, have you done any genomic testing for this patient? To find out is there any yearly resistance, that means primary resistance is also present, which could have hammered the expected resistance to the platinum based therapy. Have you done any genomic testing in this patient except the
No,
HRD?
no, sir. We have not done. We are waiting that we have sent a germline BRCA1 and 2, but I haven't done any genomic testing.
So my humble request is kindly do a genomic testing that will open up a new option for this patient. And also, as you said, the response is not that up to the expectation. So that would also could resolve for us. So definitely there is a chances that some kind of primary resistance mechanism may be there. So that could be the reason that as you expected that after the clinical trial expectation of the data is not that much response we are seeing currently. So that's the only thing I can say. But other than that, if I need to look into the very specific about the exon, which exon is getting affected because of the any changes in the resistance or the response rate difference, I don't have any data to strongly say comment on that. Right. So that's the only thing I can say. Right.
And when you're doing this HRD, is
Mhm.
that the recommendation says that only from the upfront we should do, or because most of the patient upfront we may not get adequate biopsy unless Even diagnostic laparoscopy, if you do also, we may not get an adequate biopsy to do HRD. So most of the times we send the HRD from the interval cytoreduction sample. So is that you recommend to do it from the upfront sample itself instead of doing it from the interval cytoreduction sample?
Sir, my recommendation is always when the sample is very tiny, right? So as a genomist, my preference is that nowadays some good labs are doing HRD along with the CGP itself, so that you will get the information in the upfront. But the problem is when you want to apply in the clinical practice, guidelines is not recommending any of the CGP related genetic alteration based treatment. So you are having only the HRD to support you clinically to go forward the particular treatment of either platinum based or the olaparib or PARP inhibitor based treatment. So that's the hammering point of not doing the CGP in the upfront. But if you are intent to find out whether any resistance mechanism also present in the upfront, yes, obviously a CGP along with the HRD would be the ideal. So even the samples are tiny before the cytotoxic reduction surgery. The small amount of tiny sample is more than sufficient to do the genomic testing. That's my understanding. Even 20% if it is sample is available, even small throughput biopsy is available, that is more than sufficient for us to do the testing. So in this case, it's a very odd case. How many of the patients with the BRCA mutation or how many of the patients indeed will not respond to the platinum-based therapy is very limited. So that is also another perspective to look into that. Why CGP is not required upfront. So this is the one case you needed, but not all the cases. So I would not generalize every patients need to go upfront CGP so that we will have the clarity of thought whether the platinum sensitivity also or the PARP inhibitor sensitivity upfront very clear thought will be there. So I will not go into that aspect. So currently you are having the scenario, you need to go for the genomic test. So that's all I'm saying.
Dr. Silambarasan, one more. I just want your thought on genomic score of 5. 5 is very low. See, even here, something like 30 or 35, something is okay. What is your take on this so low genomic score of 5 for this BRCA positive patient?
Okay, sir, this one really I need to give you a dicey answer for you. The thing is, the genomic score can be calculated in two ways. If persons who work in genome, maybe Dr. Suruchi would be the right person to comment on it, how they are doing the calculation. If they are doing the genomic aberration score based only on certain number of genes, basically, so there is a high chances we will miss out many of the alteration. So the aberration will be calculated based on three factors. Right, so one is the genomic alteration of the single nucleotide variations, copy number alterations, insertion deletions, everything put together only, they will be calculating the score. So that means they intend to say for us, the answer they are intent to give, the lab is intent to say for us is, we are not detecting any insertion deletion up much, or we are not seeing any copy number alteration, or we are not seeing any even point mutations. So that is the value message they are driving for us. But what I am not very sure with this score calculation is that how many genes they have done into that to give that score for us. Whether they only HRR gene, are they limited to only small panel of gene, or they have done the entire whole genome and then they are given the score for us? I don't know the answer. So that is only the challenge for me. But what is they are trying to say the message for us is they could not find out any much of genomic alteration in this patient. So that's the message they are driving for us. So Dr.
Clinically
Suchi,
also this BRCA1, it is not like a typical response to BRCA1. It's like whatever they mentioned the score for it looks like it is response to that only. So that is why whether it's a heterogeneous which is pick disease with some BRCA responsive, some just not BRCA responsive. That's what my doubt is.
See,
yeah,
VAF is 46%. That is very significant, right? It's quite high.
yeah, very high significant. So definitely I will agree with you, sir, that there is no doubt about it. The BRCA mutation is strong, but why they are not responsible as we expected to the platinum-based therapy or the PARP inhibitor, that we need to find out more information. Then only we can comment on it. As of now, we don't have the information. From the genomic aberration score, I can say that the lab is trying to say that they don't have much of genomic alterations in the holistic approach, the score they have calculated for us.
Okay. Probably you can also speak with the lab medgenome molecular scientist Narendran, because this is a very important case where contradictory report is there. Very low aberration. It's not something 30 or 35 and they call low. It is less than 5. So definitely
Correct.
better to call and discuss. And as Dr. Salambarsan has said, comprehensive genomic profile along with this, and whether if at all lab is interested, the upfront biopsy is there, you can send that for comparison. For academic reasons they can do, because it will be a very interesting case to see. So that's, I think,
Yeah,
anybody else have any
yeah.
thoughts? Probably
I
they
just
can.
want to ask Dr. Dayanjan, this patient post-op, what's the CA25 now?
And now it's normal.
Now it is normal. Are you going to
Normal.
give a June to this patient?
This patient has completed cycle 4, cycle 6 patient has completed now.
So your question is, this patient is now CA25 is normal. Okay. So why I need to ask one syllabus of Arun is setting a CPG upfront now, how is going to change our management? We're going to give one time video for sure. And he should have used, maybe could have used BEV at that initial part. But now I think it makes more sense to give olaparib and wait for the response. I mean, you'll be imaging this patient every 3 to 6 months and give C25 value. If it's rising, you will reimage and confirm disease progression. So wouldn't it make more sense to repeat a biopsy that and send for CPG rather than send the CPG now and not change your treatment plan?
For academic purpose, we can send a CGP,
Yeah,
not
so
for
academic purpose,
changing the
yeah. So
plan.
why would you want to send something for academic? Because anyway, on progression, and you still not know if the patient is not responded to PAP, you will do a biopsy that time and send it for a CPG if you really want to do it that time.
No,
The
but
patient.
Ashwin, if it's a BRCA, see, if it's a BRCA positive, it's a wrong or some error is there in
So he's going to
HRD
do
score.
he's
The
going to do a
whole,
BRCA test on germline also, sir.
yeah.
Now the
So,
germline
so
BRCA
that,
is also positive with a VAF of 34. The
yeah,
plan is
germline
almost
BRCA is
confirmed.
positive, then the whole things changes. So definitely in this case, for academic reasons, if they are doing free of cost, and if it's
Yeah,
discussed,
otherwise it
probably all
makes
these
sense
things
doing
can be
like
done.
prognosis.
Because the way we look at this patient now, everything is genomically driven. If it's a BRCA positive and HRD score is positive, the way the treatment will be defined for the patient will be totally different. So I think you can discuss, and many of the labs are now they are interested in these. They also want to learn, and they are also learning along with us. So if we can
Um,
connect to the mid genome, yeah,
Hello, sir. This is
yes, yes,
Suruchi from Strand. Yeah.
yes,
Sorry,
yes.
I'm traveling.
Welcome. Sorry,
Give me.
we have
No,
been
no,
talking about you.
yeah, yeah. No, I was in the security check. So I just want to add one point. I don't know whether it is discussed or not. But I mean, as a lab person, we do certain cases, see such kind of cases in about say 5 to 6% where germline BRCA is positive, but still we do not see high HRD score. And I mean, in the trials also, there are such reports that there could be 5-6% of cases, but I'm not sure whether PARP inhibitors will work in these cases or not. But yes, of course, tumor heterogeneity can be one thing, and the this means the effect has to be like a double hit kind of a effect. And I mean, still it is investigational right now that why such cases where germline BRCA is positive but HRD score still shows as negative, so that level of genomic instability is not noted. So when we do HRD scoring, just want to highlight, this may not be for this case, but just I mean, for the understanding, we look at the copy number profiling. So I mean, HRD score is computed by looking at genome wide copy numbers. So I mean, the scoring is based on that trust, that copy number, and the score of 5 means very low, so that means it could be very near to the normal model. So not advocating on the report, but just saying that we have to take the small amount of cases with a pinch of salt, and that's it.
Ruchi, in this case, would you recommend what comprehensive genomic profile sending at this point will add, and what sending the pre-treatment upfront before starting platinum, if we have the biopsy, sending that, will that help in this case?
See, yes, the diagnostic biopsy for checking HRD is always better because HRD is a stable phenotype. It doesn't change with the treatment as such. However, tumor heterogeneity can still be there, but the diagnostic biopsy is always better to check for HRD. CGP, if we are looking for olaparib treatment perspective, then I don't think comprehensive genomic profiling is required at this point.
Yeah.
Thank you. Thank you.
Arun sir, Kripa here. So I think
Yes, Kripa. We are
sir.
missing you.
Not really, sir. So I think this is probably one place where functional HRD could really help us.
Exactly. Yes. I think
Yeah.
we discussed this last time also, Dr.
That's
Kripa.
right.
You only mentioned,
That's right. So real-time HRD monitoring, because
RAD
we all
51.
talk about one the genomic scarring having happened already, whereas with functional HRD we could look at it as a real-time event, the RAD 51 assay as well, which actually tells us if these PAR proteins are getting localized to the site of DNA damage, and if that's happening, then we know it's proficient. But if that's not happening, then we know it's deficient. So
Yeah.
I think sure, Dr. Suchi, please go ahead.
Dr. Kripa, do you know any lab is doing this? Because I was just looking at if that is happening in India, and maybe
Yeah.
we can just if that is
Unfortunately,
being
correct. Unfortunately, it's not yet happening in India, but it's being done abroad. The Genomic Health
So
Science Laboratory.
is there a scope of adoption in India? I mean, should as a
Yes,
lab we should look
definitely,
at it?
definitely.
I mean,
I think it's definitely something that should be looked at, because if you have something like a real-time HRD monitoring and that can tell us as to how it is at that point in time, I think that would be very relevant for clinicians, for us to apply it into practice as well. Because, we're relying on this as a one-time event or, something that's happened as well in the past. Whereas if you could do a real-time monitoring and see if there is actual functional HRD, then I think, it would definitely have therapeutic implications, especially in, these sort of cases.
Yeah. So as a lab, if I say that if we start this kind of a project to validate this assay in India, would there be kind of a collaborative effort, and can we get we need some tissue and slides, right?
Absolutely. Yeah, I'll tell you, for example, Oncostem Diagnostics, Dr. Manjure, she started off Can Assist in a similar sort of way because they wanted to replicate what was being done in the West with Oncotype DX. And that's how today we have ended up with Can Assist. So I think that's something which can be done, which, we can all come together and we'd all love to all collaborate on that. I'm sure Arun sir would also take the lead on that. So, yeah.
Because last time when you spoke, sorry,
we will do it, Suchi. That's not like we are willing for collaboration. We are doing a lot of collaboration also, so definitely we can do it. So we can make it a good model actually. So that's not a problem. But see, for me, it's very important to define whether this patient is BRCA positive or not, because the way we treat the patient differs. So here, one end BRCA is positive, another end is HRD is negative. So either now or when the patient relapses, we need to have a clear margin whether how we are going to see this patient. So if there is no cost constraints, yes, do everything now. If there is a cost constraints, proceed with olaparib plus bevacizumab. At relapse, redo the whole thing.
Right, and HRD is not, so the score is not determining of HRD. Basically, if BRCA, as per the definition, even if the BRCA is positive, HRD status is considered as positive irrespective of the score. So that's what the trial.
Yes, Suchi. But this case, although BRCA is positive, HRD score is negative. Platinum response also is not
seen.
So clinically also she is not responding like a HRD positive case. That's the problem. If this same patient after platinum complete pathological response and this report, then I think most of us won't even discuss. We'll take it as BRCA positive and we'll proceed. So here the scenario is on a different side.
And
is germline confirmed, sir?
Correct. That's what.
No, is it confirmed?
They've sent. Narendran has sent that. He's awaiting the report.
Yeah. Okay, sure.
Okay, thank you.
I think.
Thank
Okay.
you,
Chandralekha, can we just summarize this case? So, would you like to summarize, or shall I do that, Chandralekha?
Sorry, I will do, sir.
Yeah,
so this was a very interesting case, which there's a lot of thought process going on where there was great discordance between the BRCA mutation and also this genomic aberration score. So, as of now, the treatment is to proceed with olaparib and bevacizumab, and subsequently, we are also waiting for the germline testing and whether any possibility of doing the same testing in the upfront diagnostic sample is also the other thought process we had. And other thing what Kripa sir told, like regarding the real time HRD, that is functional HRD, it also is also to be considered. Then sir, so Narendran sir also has other case, right, sir? So we can proceed with Dr. Narendran sir itself.
And also, just to add to that, I think Zydus is also rolling out their Myriad My Choice CDX test. They're rolling it out.
Okay.
So I think Narendran, if your patient can go in for that, you could get that done as well, because Zydus is rolling it out.
Okay.
Yeah.
Okay,
So
so
this
we'll
is
start
case
the next
two.
case, sir. Yes, sir.
Case 2, this is 74-year female intrahepatic cholangiocarcinoma with omental and peritoneal nodules. It's biopsy and IHC proven, and patient was initially started on patient has multiple comorbidities. Initially, she was started on Gemox, and post 6 cycles of Gemox, she had a good response. But the patient was not willing for further IV chemotherapy, so we switched it to S1. After 3 to 4 months of S1, now the almost 5 months of S1, now the disease progression is there, and head to IHC is negative, PDL1 is negative, and we have sent a comprehensive genomic profile. And since the patient is not willing for any IV chemo, I started on metronomic therapy now. So now, can you go to the CGP? So this TMB score is low, MSI is negative, and this IDH2 mutation is positive, and TP53 mutation is positive. Can we go full report of this CGP? I think one more page is there where it shows the head to amplification was there. In the same report, down it was that. Okay, head to
Yes.
amplification was there.
Yes, Narendra, there was, I think that I'm not able to see. 12 copies were there in head to
Yeah,
amplification in your.
copy number gain was there. So, so the head 2 is negative. So, but copy number gain was there, and again it is IDH2 positive, not IDH1 positivity. So my choice is to continue metronomic chemo for whatever benefit, and then to add on probably immunotherapy or future line la best supportive care. This is what I can see with this CGP. Any other suggestions?
No, so Narendran, your patient is very clear that that the patient doesn't want any IV therapy, is it? So that's
Patient doesn't want any IV therapy, sir.
okay.
Every time she comes, she cries for IV. Only tablet she wants.
Okay. So then that sort of boils down narrows it down. See, I think task one.
Discussion will go for IV, and for discussion purpose, we'll discuss IV also.
Okay. See, I think targeting IDH2, is, I mean, like, we don't have access to these molecules. We only have access to ivosidenib, which is an IDH1 inhibitor.
One,
Here you're
yes.
talking about IDH2 mutation, and
Mhm.
these inhibitors are not available to us. Probably Servier will launch vorasidenib by next month, so we should have access to vorasidenib, which is a both IDH1 plus 2 inhibitor vorasidenib. So we could look at using that, but albeit it's not yet approved for use here in cholangio. So it's an off-label indication, right? I mean, like, if you want to look at getting it and using it, albeit if your patient doesn't have any financial constraints, then probably that would be an option to go forward. I mean, like, look at targeting that. And as far as the copy number gain, that's interesting, the HER2 copy number gain. So, if at all your patient was okay or, was willing, I would much rather use, look at probably using TDXT over vis-a-vis immunotherapy here. Because it looks like the tumor microenvironment is pretty cold. TMB is low, MSI is stable, and also this is in the second line as well. As far as IO is concerned, so I wouldn't really be too keen on adding IO here, Narendran. So if at all you want to look at adding a second line patient is willing to take some IV drug, I think I would look at probably using TDXT in this setting.
The Femto score is 0, sir, but whether how much
Again,
will be
yeah, that's what.
beneficial
So
with receptor?
correct. So we always talk about tumor heterogeneity, right? I mean, like
Mm-hmm.
both intra-tumor and inter-tumor heterogeneity. So I think that could be another reason as well. So you could even look at repeating another biopsy if at all it's feasible to repeat it from a different site and get it done, get an IHC done as well again, and do FISH as well just to check on it. And if that's possible, then I think I would definitely look at offering TDXT as an option if your patient is keen on taking IV medications or is okay with taking IV medications. Else, you could go for off-label IDH2 inhibition. I think those are the only which
Is
you're
there
looking.
any data on tucatinib here? Like at least I don't think there'll be any high-level evidence. But this patient is not willing, and HER2 amplification is there. And definitely we need to do a FISH, that is for sure, because HER2 amplification IHC is negative. Probably we can check any data is there on tucatinib in this particular case. So probably that may be one pathway where we can target oral she wants. She is not willing for IV. Probably any data is there, we need to check.
Okay.
She,
I think the thing is, sir, with these TKIs or small molecule inhibitors, as far as HER2 targeting TKIs are concerned, tucatinib is very selective. We know that. I mean, like it's not like naratinib or afatinib, which are all pan blockers, HER1, HER2, and HER4. Whereas tucatinib is very selective. Like lapatinib is both EGFR and HER2, which is HER1 and HER2. Whereas tucatinib very selective for HER2. But nevertheless, it's definitely not approved yet, and obviously there's no phase 3 data for sure. So we might have some earlier data, but I don't know how far we could push that. And if that's the case, then I might as well look at targeting the IDH as well. So, I mean, like if cost is not a constraint and the patient can afford to get those molecules as for acid, and then I think.
So for CA lung with EGFR with HER2 amplification, there is some data where afatinib works well. When there is both EGFR and HER2 amplification in CA lung. So in that case, can we extrapolate and use afatinib here? Pan HER2.
So, no, see, the thing is, there is data for afatinib even in NRG1 fusions and all of that as well. All the uncommon EGFR mutations and all of that. But let me tell you again, that is not, level 1 data, or, it's not based on very strong. Like, for example, even osimertinib in uncommon mutations based on the unicorn study, there is data. So I think it's all about the strength of the data when you're looking at quoting it. And here, especially in cholangiocarcinomas, I think we've got to be very cautious before we look at interpreting the data. At least TDXT has got a pan tumor agnostic indication, so that way it's all right to go ahead and offer it as an option. But the others, we really have to look at either explaining it to the patient, telling them it's a completely off-label indication, or looking at like we said earlier, we'll have to prove the HER2 as well, looking at doing a FISH check if the FISH is if it's actually amplified, or look at getting a repeat biopsy rule of tumor heterogeneity. But I think is likely to be a driver.
Dr. Narendran, sir, can I comment on it?
Yes, sir. Yes, sir.
So coming back to the CGP report you are having, so there is a clear evidence that the driver mutation should be IDH2. But unfortunately, like Kruba sir mentioned, that the drug is not available with us, or even if you are trying that, it will be off-label treatment. So going with the next choice, best option is ERBB2. There is no doubt about it. And as already Arun sir as well as Kruba sir mentioned, you need to go for FISH testing to rule out whether it's a ERBB2 low or ERBB2 high. From here to low or here to high. So based on that one, and also they don't want IV treatment. So in that all the put together scenario, you have one more option of submit trial data, which is neratinib basically. So in the BTC, it is there, which even though it's a phase 2 data, so you have submit basket trial data. So based on that one, you can think about neratinib is also a small bit of option is there, but the first choice has to be deruxtecan, TDXT. But if the patient is not willing, not at all want to take any IV treatment, then you want to still explore, then niratinib based on the phase 2 summit trial data also, you are having one more option. So, and also it is worked very well in the BTC condition. So, definitely it would be much better if you are already thinking about afatinib. I would stay away from afatinib and even think about niratinib as a better choice than afatinib. So, that's one additional point I want to add on from the discussion.
The other thing
Okay.
about niratinib is that, wherever, I mean, I've used the drug on a couple of patients so far. Toxicity
Diarrhea.
concern, absolutely definite concern. If you look at the control data, even in breast cancer, they recommend that you start at 120 milligrams and then escalate weekly. So, that's the best. You can never reach 240 milligrams. It comes as 40 milligrams. You'll have to take 6 tablets. So, it's not a very easy drug to handle as far as naratinib is concerned in practice. So, in fact, I would much rather say it's easier to give off an IV medication rather than using naratinib. I mean, just purely from an adverse effect point of view or a side effect profile. So, yeah, I think, you'll have to discuss that really. I mean, like if your patient is really driven enough to do that, because if she's worried about toxicity and that's the reason why she's avoiding IV, then, you got really.
Okay. Okay, sir. Thank you.
So, what have you concluded, sir? Like, so you're planning, sir?
This patient, the next best option will be if patient is affording, we can send for a fish for head 2 or repeat biopsy and look for heterogeneity in head 2. So then go for a transdermal deruxtecan if willing for IV. So if not willing for IV, then other options like IDH2 inhibitors, vorasidenib is another option. So, or if not there, then other options are neratinib and afatinib discussed, but toxicity is still concerned. So this is what final discussion went. And so if no, my conclusion is if not not willing for anything, then next line I will go for best supportive care.
Fair enough.
Thank you.
So, with the role of doing CGP, we are getting to see a lot of uncommon mutations together, like these patients. So, we'll move to the next presenter for today, who's Dr. Isha Tiwari from MS Ramaya Medical College. Doctor, you can start presenting, Doctor.
Thank you. This is a 48-year-old female with milk comorbidities who was being evaluated at Varanasi for complaints of cough on and off since 2 months with weight loss, which was not quantified. She was a non-smoker. X-ray shows some patchy areas of consolidation in the right lung. She underwent a CE-CT scan, which showed a thick, irregular wall cavity with internal necrosis in the anterior segment of the right lower lobe, size about CT2, with the right middle lobe bronchial narrowing because of the compression of the endobronchial obstructive lesion. The biopsy showed well-differentiated adenocarcinoma. Sir, there is one correction. We revisited the scan. It's not stage 4, it's stage 3A. Initially, we believed there were nodules in the opposite lung. We have discussed it. It's stage 3A. She is currently on NACT with pemcarbosel. Since she was a non-smoker young female, we had sent an NGS also. Sir, in that, it has come as a mutation positive for PIK3CA and PDL1 score of 80%. The other mutations have turned out to be negative. We wanted to ask, sir, whether this mutation is it targetable in lung? We have not given it for anybody. Hello, sir.
Yes. So go back to the genomic data.
Yeah. Hello, sir.
Yes.
Yeah, can you hear us?
Yes, I can hear you now, sir.
Yeah, perfect. So you're saying this is somebody with stage 3 lung cancer, is it? It's not stage 4.
Yes, sir. Yes, not stage 4, stage 3. We had also taken opinion for surgical oncology and radiation. Surgery was not deemed feasible, and even RT was not possible because it was very close to the main bronchus. So now we are planning to give chemotherapy and then reassess. She has received only first cycle. She had come for a second opinion. By that time, this NGS had come, sir. It's showing PIK3CA mutation. So, and it's a CA lung. So we wanted to discuss whether is there data regarding this, sir?
See, definitely
May I know
not.
the vast percentage in this part?
Yeah, I think
Sir?
this PIK3CA mutation is an exon 9, earlier exon 9, now exon 10. So this is a known hotspot mutation. But nevertheless,
Okay.
we don't have the data to target it, and especially not
Yes.
in a localized disease. When you run out of options, if you've exhausted all of your standard of care options, and then you're really looking at salvaging it, let's say in the third line or fourth line or beyond, then probably you could look at using just like tumor agnostic therapy. But otherwise, we don't have the data, especially in stage 3 lung cancer, for us to go ahead and target the PIK3CA, even if it's a hotspot mutation that's been picked up. So I think fair enough that the patient is already on chemotherapy, but have you contemplated adding IU as well?
We have, sir. PDL1 is about 80%. We have
Yeah.
counseled regarding.
Yeah, so I think you should.
Sir, if
Yeah,
yes,
go
sir.
ahead. Yeah, so I think
Sir, just wanted to ask you.
so you're doing it as a neoadjuvant approach because stage 3 you're
Yes,
saying.
sir.
So yeah,
Yes,
then
sir.
your neoadjuvant chemo plus IO for 4 cycles, and then you can go ahead and reassess, do a repeat imaging, take a call on local therapy, albeit surgery or even radiotherapy at that point in time, and then go ahead with consolidation with durvalumab as far as stage 3 disease is concerned.
Okay, sir. Sir, suppose if after 4 cycles the PET-CT shows progressive disease or say metastatic, then are we justified if at all we try to use this mutation?
Not really, because even if it is, progressing after 3-4 cycles, because that means it's in the first line and you've not exhausted your standard of care options yet. See, like for example, if you're doing chemo plus IO, second line you still have your ramucirumab plus taxane or docetaxel, and then again you could repeat a biopsy at that point in time, understand why there is a progression, look at identifying the mechanism of resistance, look at targeting that as well. So everything will depend on the mechanism of resistance at progression, right? You could have, I mean,
Yes.
there are multiple mechanisms. You could even have a small cell transformation. So it'll all boil down to what your mechanism of resistance is at progression. But as of right now, not as at the time of first progression, pick 3, you're targeting the pick 3 right up front. Definitely not a go, not your go-to option as far as non-small cell lung cancer adenocarcinoma is concerned. This is adeno, right? It's not
Uh,
carcinoma.
Adeno, sir. Adeno, sir. Sir, also wanted to ask you, in a non-smoker 48-year-old female, the fact that there is no mutation which is turned up, how common is it, sir?
See, see, we know that we know that not 100% are going to have any targetable or driver or actionable genomic alteration, right? So definitely
Okay.
not. So even if you're saying 70% are likely to have some alteration, here she could be one of those 30% who don't have any of those targetable. I'm talking about targetable driver mutation or actionable genomic alterations. And PIK3CA here, the same. It's not the same. Breast cancer is not the same as lung cancer. So here,
Okay.
if you're talking about pathway alterations here, targeting PIK3 in the first line, definitely there's no data, and it's not based on evidence as well. So, like I said, the standard of care, still remains. For example, if you're leading with neoadjuvant therapy, it should be chemo plus IO because your PDL1 is pretty high as well. So chemo plus IO should be your go-to choice of regimen here, and then you can take a call on RT. You said right
Yes.
now it's not amenable because she's
Yes, sir.
it's close to the bronchial, and that's why you're not contemplating RT right now. But then if you have a good enough response, I think you should consolidate with CTRT and then offer even
Okay.
IO maintenance as well. And that should be the
Okay.
standard of care. The standard of care is not going to change based on the presence of a PIK3 mutation, albeit even if so it's a hotspot on exon 10, E545K. I don't think you should
Yes,
change
sir.
your management based on that.
I
Thank you,
think,
sir.
Doctor, at 45 adenocarcinoma female, I think most of the data, 40 to 50%, you will have some mutation, and rest 50% may not have actionable or targetable mutation. That's the data. If you go for comprehensive genomic profile, if you go for a hotspot or focus, only 25% will have some. So rest 75%, they won't have anything. But that's why there is a lot of debate whether upfront in lung cancer you should go for CGP or focus hotspot mutation you should do. There is a lot of debates. And a lot of recommendations also, you can see there will be some recommendation telling that go for CGP in second or third line. Upfront, if focused or hotspot mutation is more than fine. That's what some of the recommendations do tell. So this is always there. This is common scenario. Nothing like it's unusual. Only 4 out of 10 will get benefited with CGP what we send upfront. So rest 6, we may not have any actionable mutations, and the NGS may not help us in deciding the treatment. This is normal for all of us. I think it's not unusual.
Yes. Thank you, sir.
Thank you, doctor. To consolidate this case, this 48-year-old lady, stage 3
One
lung
question.
adenocarcinoma, and since she is treatment naive and also a good score for PDL1, probably we can try the immunotherapy upfront. And since PIK3CA is not targetable as of now with lung cancer, and this was a CGP done at initial presentation. This also gives us a thought going back to doing a limited panel for the lung cancer. So we'll consider it later
Can I add one more
regarding the
point?
people.
Can I add one more point?
Yes, sir.
Can I add one
Yes,
more
Yes,
sir.
point
Yes,
in this
sir.
one?
yes, Simbu. I think Simbu wants
Yes,
to.
sir.
Okay.
So can
So
it
one
be
thing,
neurofiber?
what,
Can we? Is it possible only in not adenocarcinoma? Any other neuronal organ? Because NF1 is positive. We know peak 3 can come with NF1, but should we rule out any other histology type?
As in, you're talking about a family history of neurofibromatosis, or you're talking
Atypical
about
No,
one?
sir.
because it's an endobronchial lesion. We
Okay.
can carcinoid also common for endobronchial.
But she said clearly adenocarcinoma. I think they've done IHC.
Adenocarcinoma, sir. Yes, sir.
Yeah.
No, sir, they've not done IHC. They've documented in pathology as well differentiated adenocarcinoma.
Well differentiated adenocarcinoma. Yeah.
But what is the VAF of NF1? That would be interesting to see. 30%, almost
good enough
similar
that,
like TP53. Yeah.
Yeah.
Okay, sure. Thank you.
so
Can we suggest IHC here if suppose for completion's sake?
Yeah, no harm in getting it done. But I think if it's already well differentiated adenocarcinoma, may not change our treatment decision or your management much. And also about this broad-based versus limited NGS panel, it's interesting because I think it adds in that it adds to your prognostic information, number one, and also you're able to pick up co-mutations as well. So and we've seen in a lot of patients that also probably tells us who's likely to derive magnitude of benefit. Like for example, KRAS with STK11, KEAP1, SMARCA4, or even your EGFR with P53 co-mutations and all of that. So yeah, I think it works both ways. I mean, yeah, like Arun sir also rightly pointed out, if you can get it done upfront, it helps you understand whether at probably clonal evolution and selection pressure hypothesis, is it a primary mutation or was it acquired later on? So in that sort of sense, yes, it does help you. May not actually have major therapeutic implications right away upfront, but prognostic and helps us understand resistance mechanisms. Yes.
Sir, one last question.
Yes.
Sir, we have been taught that whenever if in the histopathology they mention even if it is that favoring adenocarcinoma, we need not run IHC so that we can save the tissue for NGS. For example, sir, in this case, had this NGS report come and the tumor would have been reported as poorly differentiated adenocarcinoma, in that case, would you recommend IHC?
So yeah, I see if your pathologist has called it poorly differentiated carcinoma, then I think definitely yes, no doubt about it. But if they're very clear, if your pathologist is very confident and is calling it based on histopathology or based on just the morphology, they're calling it an adenocarcinoma, I wouldn't want to waste tissue by doing a IHC here. I would much rather do an NGS, like you rightly said. Because tissue is always an issue wherever you go as far as solid tumors are concerned. So I think yes, an IHC definitely is not always mandatory, especially if your pathologist, based on morphology, has told you that yes, this is, like in this case, has told you that it is well differentiated adenocarcinoma.
Thank you, sir.
yeah. So I want to just add one point, which is half-hearted answer only. So you are decided to go with the chemo immunotherapy combination, right? So there is one thing you can mildly take into the consideration that the patient have mTOR loss also, right? But only my concern is the copy number, which is only 1.3. So do we need to really take into that as a real MTAP loss or CDK2NA loss? If it is really MTAP and CDK2NA loss, it is considered as chromosome number 921 loss. So if that is the real scenario, this is considered as a cold tumor. So you can only expect, not act on it, expect that immunotherapy may not respond better. So in case we are going with chemoimmunotherapy treatment and if it didn't responded very well, you have the answer already in this report, which is MTAP loss and CDK2NA loss. But only my concern is the copy number is only 1.3, even not even 4, not even 5, not even 6. I don't know what is the cutoff they are want to do the reporting. Since it is from the garden and also it is from the homologous deletion of CDK2NA biallelic loss, I am sometimes suspecting that the immunotherapy may not work. So cold tumor condition is there. So just caution, just watch out. If you are going for immunotherapy, it will be good to document also whether immunotherapy response is there or not. So I'm also eagerly waiting to see whether it is there or not.
Yeah,
So
but
only thing I can say is switch like cold tumor. Yes, sir.
my just continuation with Kripa, the question asked by the presenter. The histology, I think most of us will be trying to do IHC when it comes as a poorly differentiated carcinoma is to decide whether we need to go with pemetrexate based chemotherapy or not. We know that if it's pemetrexate, it should be adeno. That is the only area where we are more interested to see whether adeno or squamous. Otherwise, even with adeno, most of us, we want to know whether any genotypic, whether it's a targetable mutation is there or not. That is the most important thing. The chemotherapy per se, where IHC, most of us we would like to get is to see whether to go with pemetrexate based combination or Taxol based combination. This is where IHC we all ask for. Point number one. The second point, as Dr. Salambarasan said, where although we don't have targetable mutation, here certain co-mutations may help us to understand that probably immunotherapy PD-L1 is high positive. Still, patient not have that good response as we expect for high PD-L1 because of the co-mutation. So these probably these co-mutations can help us to predict how the response will be, so that we'll do a early response imaging to see whether immunotherapy is working or not. All these things will be helpful, but there are only certain areas where CGP helps in predicting the treatment. But most of the times for prognosticating and doing early imaging, definitely doing a CGP upfront, even in first line, it helps.
Right. And just to add to what Salambarasan was saying, probably could reflect a tumor, some cold tumor microenvironment. But remember, this is in the localized setting where the primary tumor is still intact and your immune priming is much better. We always talk about immune exhaustion happening later on in stage 4 disease. So this is not stage 4 and this is stage 3, as was pointed out earlier. And again, this word about MTAP loss, which is where they're looking at PRMT5 inhibitors, and a pemetrexate also works well in patients who have MTAP loss as well. So I think, that is also just to add to what Salambarasan was saying. Yeah.
So that's a point also I want to discuss. Like anyway, you are going for chemoimmunotherapy. Instead of taxane, you have one more option of pemetrexate. So do you want to go with this based on the genomic skeptical of MTAP loss instead of taxane?
I think they've already started pemetrexate, if I remember right. Is that right?
Yes, sir. Yes, sir. First cycle has been given. Pemetrexate has been given, sir.
So yeah, you're already, yeah.
Then already you are in the right track, basically. Yeah, that's all I want to say.
Thank you, sir.
Thank you, sir, for this all these inputs, and we'll move ahead with the next case, that is Dr. Tara Chand Gupta. Yes, doctor, you can start presenting.
So, good evening, all. So, this is a 56-year-old male without any history of any substance use, with a hypertensive male. He was having anorexia, weight loss, and abdominal discomfort at the baseline. An upper GI endoscopy suggests that it was esophageal junction growth, and PET CT scan is suggestive it is a metastatic GE junction mass that is mets to the peripancreatic lymph nodes and abdominal lymph nodes, and etc. Histopathology was done that was suggestive of adenocarcinoma, signaturing cell morphology. Cells are arranged in the palisading manner. So, Next slide, please. So patient was labeled as the metastatic adenocarcinoma of lung, and ISC for HER2 was negative, PD-L1 was 3%. He received initially, he received the modified FOLFOX plus tislelizumab, so around 12 cycles of FOLFOX and 8 cycles of tislelizumab. After the midterm evaluation, patient was having very good partial response, or you can say near CR. But when the completed total 12 cycles of FOLFOX, 11 cycles of FOLFOX and 8 cycles of 12 tislelizumab, there was a disease progression. So repeat biopsy and comprehensive genomic profiling was performed that shows that the PDL1 CPS 12 and PMR TMB low, HRD negative and negative for Claudin 18.2, and no other target mutation. I think report is also there. So we are planning for the next line of management. I think one report is must be there. This is the report. So that is suggestive of these mutation. Only the PDL1 is positive. That is the only positive marker. But go away in detail. So we can discuss how to proceed in this case. I think detailed report is also available where some mutations were identified like the FGFR3, CTLA4. Do we have a full report? Yes, this is the report where these are mutation T53, NOS2, and FGFR3 fusion CTLA4 were identified, including CDKN2. So now how we can choose the best drug which can target these mutations to give the maximum benefit.
Hi, sir. This is Dr. Krupashankar here. So I think
Yes, sir.
I think it's safe to say that you can disregard all the VUSs as far as therapeutic decision making is concerned. So variant of unknown significance or a tier 3 is definitely not meant for therapeutic decision making. So you can safely disregard all the VUSs as far as for treatment therapeutic decision making is concerned. I think I would agree with your choice of having to go in with ramucirumab with taxane, which is the current standard of care in second line for adenocarcinoma stomach, with the patient having progressed on IO in the first line, chemo plus IO, the patient has progressed. So the second line ideally would be ramucirumab with a taxane. Given with all the genomic data that you've shown us as well, I would still prefer doing that in practice because that is the current standard of care in the second line. Like I said earlier, once we've exhausted all the standard of care options, then we look at what's experimental or what we can do off label. But as of right now, I think yes, and irinotecan also is another option which patient has not been exposed to, TAS1, 0 to S1. These are all options which the patient has not been exposed to until now. So I think, I would also agree with your choice as far as ramucirumab with taxane.
Professor, there is one oncogenic mutation also there, which is FGFR3 TAC3 fusion.
But
Which
it's
one?
not tumor agnostic.
Yeah.
I think it's approved in bladder, definitely,
And also,
but it's not tumor agnostic. Probably we can reserve it at a later date if the fusion is present. So probably not now. That's what my thought is. Is more if it's a bladder, yes, there are trials where we can use erdafitinib in this particular situation.
and
But
again,
here, I don't think it's approved.
correct. And again, just to highlight what Arun sir has said, FGFR inhibitors are approved in biliary tract cancers and also in bladder cancer, urothelial carcinomas. The difference being that if you look at the FDA labeling, it is for FGFR rearrangements in biliary tract cancer and it is for FGFR alterations. By rearrangements, they mean fusions as well with known partner genes and unknown partner genes as well in biliary tract cancer alone. Whereas in urothelial carcinomas, it is for alterations, meaning including mutations also, but not for amplifications. So it is for
Dr.
mutation and
yeah.
in bladder cancer. And in like I said earlier, in biliary tract cancer, it's for rearrangements. Yes, sir. Please go ahead, Dr. Sarjan.
So, Dr. Krupashankar, just one query that if we are avid with only that the FDA approvals and the specific tumor type approvals, then I think we should test only the 30-40 genes only, not the complete panel, because we have the targets for those 40 genes only.
No, see, the thing is, again, like we spoke about earlier, for example, subsequent lines of therapy. Now you know that this patient is already has a FGFR fusion, right? So you could also understand better at progression. For example, you repeated this at progression as well, right? So was there any discrepancy from the baseline to the progression at the time of progression? Was there, when you did it at baseline, was there an FGFR fusion as well? The
No, we
FGFR
did
being
not. No, we did not do any FGFR and any alteration test at the baseline.
Oh, so you did not do it at baseline. So,
No, no, that was only the biopsy, ISC, PET scan, and that
you
is
only did
the
HER2.
routine workup.
Oh, so you only did HER2, MSI, PDL1, and Claudin 2
Yes,
at
yes,
that
yes. At
point in
that
time.
time.
So,
At that time, PDL1 was only 3%.
yeah, but now it's 12%. So I think, that's why probably it's important for us to understand whether it's something that was present at baseline or whether it's been acquired as a resistance mutation, which is something we won't know now. But having said that, now that you've done it, we know, I mean, like now the patient does have a FGFR fusion, but albeit you've not exhausted your standard of care options. And that's the reason why they call standard of care, is because they're already time trusted and proven therapeutic options. So when you still haven't explored them, why would you want to go on to experimental therapy or off-label indications? So which is why I'm not saying you should never use it. All that I'm saying is use it in the later lines of therapy when you've exhausted your standard of care. And you've definitely not exhausted your standard of care here. So yeah.
Yes. Yeah, so this is same previous presenter also we said the same. Every time we ask this question whether we should go for comprehensive genomic panel or not because of the cost constraints, and many of the time we won't act on the mutation that we see. So every time, and you can see most of the labs are offering gene panels and hotspot panels alone. So every time we have an option whether to go for only hotspot focused mutations alone, or whether we go for comprehensive genomic panel. There are a lot of recommendation also are there when to go for comprehensive, when to go for hotspot. Definitely, you asked a very valid question. It's all ultimately you need to explain to the patients, and cost versus benefit we need to discuss, and then we need to proceed. And first and second line, many times comprehensive genomic profile, it's more of prognostic, less of predictive actually. But later lines, probably third or fourth line, probably it is more helpful. That's what most of the studies to tell. It's a very valid question what you asked.
So one thing is that nowadays we are doing NGS in lung and upfront settings, and we are guiding the treatment accordingly. And I quietly remember that there was the time also that we should do these tests after the chemotherapy exhaustion initially. So things came up with the time, and now we are saying that if the mutations are there, then we should target first. And second thing, what is my learning is that, so initially there was a FNAC only to diagnose the cancer. Then it came to the biopsy that shows that this type of cancer, and then the ISC came that this cancer belongs to that organ. And the futuristic thing that it may be a CGP or anything that will tell that this is genetically this cancer, genetically this tumor belongs to this cancer, and you should treat like this. So that's why I think that concept is with the CGP. I don't know I am right or not.
You're right, Darcy. For example, when we talk about doing a CGP, we know as far as tumor agnostic markers are concerned, TMB is a tumor agnostic marker. And for you to check on your TMB, you need at least a 300 gene panel if you want to accurately estimate the tumor mutational burden. So I think if you're looking at, and we know that's already a approved tumor agnostic therapy for TMB high patients. So you're already agreeing that you have to do a larger panel if you want to look at your TMB. Even for later lines of therapy, because that's already approved. So again, it brings us back to the same question. See, for example, your MSI, TMB, I'm talking about tumor agnostic therapy here. So again, your RET, BRAF, all these have a tumor agnostic indication right now. So I think, if you're looking at, having to know all of that information, yes, please go ahead and get it done.
And for the discussion purpose only, that I'm not being adamant for this. The
No,
thing
no.
is that I have seen came across two trials, one in the hepatocellular carcinoma and one in the pancreatic cancer. Although those two studies were the retrospective studies, one was published I think in 2019 or 2020, and second was in I think 1 year or 2 year later. where initially they go with the comprehensive genomic analysis and find out the pathway and targeted the cancer accordingly. And retrospectively, results were better those the past prospective studies. Yes, that is a caveat. That was a retrospective only.
Absolutely. Thank you for sharing that, sir. Yeah.
Sir,
I
one
think we need
point
to
to
proceed.
add. Sir, one
Yes.
point to add for the treatment of the second line choice selection, which is recommending is your choice of ramucirumab. Right. So go back to the histopathology report. I have one point to add on. I'm feeling that it will be helpful to you beyond the genomic data, not this one. Go up the histopathology report. Histopathology report. Histopathology. Histopathology.
Yes, sir.
Yeah. Stop. Go down. Yeah. So here in the last line, if you look at the last line, the cells are arranged in palisading manner. So whenever the cells are arranging in palisading manner, so there is a chances that the tumor is trying to create a hypoxia microenvironment. So that means the neovascularization may be present. So maybe it's good to check with the pathologist. Is there any microvasculature they have seen more often over there? So in that case, ramucirumab currently you are going to select in the second line treatment may be helpful because it's a VEGF inhibitor. So that is the only one line I'm thinking that beyond the treating the FGFR based treatment, keep it in the reserve line. But here, since the palisading pattern is we are observing in the histology, just check with that whether microvasculature is also present. That means blood vessels also more commonly seen in the tumor. That means the ramucirumab, which is a VEGF inhibitor, will be helpful in this case. And then definitely we can think about the tumor agnostic based treatment later lines on that part. So that's the one point I want to I observed in the histopathology report. Just I want to convey.
The other thing is the signet ring cell histology. We know that's a poor prognostic indicator as well.
Yeah, as well. So two information you can derive from the histopathology report. One is signet, so which is the poor indicator. Another one is palisading manner arrangement, so which means hypoxic environment is created. And no wonder IDH, something like that mutation, if it is there in the future, if you are seeing that, that also can come up. But right now, ramucirumab may work for the patient because of the hypoxic environment. Just check with the microvasculature if it is present or not in the histopathology report. Then you can think about the tumor agnostic treatment whenever the patient failing in there.
Thank you, sir, for the presentation. To conclude, this 56-year-old gentleman had a metastatic adenocarcinoma of the esophagus, who initially responded very well to the combination of Folfox and tocilizumab, and after that, he had progressed. And the CGP, we had a good discussion about how does a CGP usually helps in a prognostic way, and subsequently may be useful if we look back for doing retrospective studies also. Then, so as of this patient is concerned, FGFR3, which was present for this patient, may not be used at present without indication, and we may consider at a later point of time. And right now, we can go ahead with the second line management with VEGF receptor and VEGF antagonist and taxane based therapy.
So, madam, if
Thank
this
you, sir.
patient progresses on second line, then how will we guide the treatment according to this CGP?
As sir has
Because this
already
is a
mentioned
G
that
junction tumor, so he will progress
yeah,
within 3 or 4 months usually.
yeah, definitely. Maybe the subsequent line of chemotherapy, and if you have exhausted the other modalities of chemotherapy, we can use it as an off-label. And right now, no, we can't rely upon that FGFR antagonist right now, as sir has already mentioned about that also. As an off-label, we can use in subsequent line of therapy.
Madam, SARS concern is if I use the second line, within 3 months the patient will progress and then they will go into faster progression. At that time, my tumor agnostic will not be a choice for me at all. So that's what he's concerned also. So it's a touch and go, sir. Both the
So
sides
again,
are there.
Yeah, we do have other oral chemotherapy options also, which we can give a try for that patient, because anyway metastatic adenocarcinoma, we know how it is going to progress. We can use the subsequent line of chemotherapy as well. That is my take.
correct.
I think anybody.
Correct. So I think the other lines of options are TAS-102, S1, irinotecan, all of
Yeah, we have
number
a number of options
Number
as
two,
well. Yes.
number two, you could also look at repeating another CGP at progression. Look at what's driving the disease at that point in time. We can't predict how the persistence mechanism is likely to be right now, right? Especially post ramucirumab plus paclitaxel, the patient is progressing. Look at identifying the mechanism of resistance at that point in time. So, and then we can go ahead and act on it at that point in time as well. So I think for me, we don't have to be in a rush to go ahead and target the FGFR as an off-label indication right away without having exhausted our standard of care options. See, I mean, like we always talk about signet ring cell histology is not doing well, but this patient seems to have responded very well to immunotherapy and almost reached near CR as was shown earlier, right? So we don't expect to see that usually, but this patient has responded and subsequently has progressed now, and that's why they've repeated a CGP now. So you can never predict when a particular patient is going to progress or what time frame is it. We know there are responders and there are poor responders as well. So it'll all boil down to the mechanism of resistance. At that point in time, you can repeat another CGP as well and then take a call. But as of right now, I think ramucirumab plus taxane would be a go-to choice.
Okay, sir. So we'll conclude this case and move ahead with the next doctor's presentation. We have 4 cases from Meenakshi Medical Mission, and now Dr. Muttumanigandan sir will be presenting the next case. Yes, sir. You can.
Yeah, thank you, ma'am. So my case, he's a 32-year-old male. He's in lymphoma from conjunctiva, stage 1E. So the date of diagnosis is October. Now the patient is on stable disease, so the ECOG PS1. Next slide. The biopsy was done from conjunctiva, though the specimen type is a tissue specimen only. So the findings was the lymphoma with T follicular helper cell phenotype. That was our biopsy findings. So next one. Actually I'll come to the biopsy first and then I'll ask the question. Next one. Next one. Next slide. Next one. Yeah, this is the first biopsy report. So initially the biopsy report it shows just a minute. So it was an excision biopsy from the conjunctiva. So it shows actually the T cell lymphoma. The initial biopsy from Aravind was it was done initially from our outside hospital. So it came out to be T cell lymphoma. Next slide. So we have done the biopsy review, block review. So the final review, actually the slide has been cut in this. Just a minute. Yeah. So the initial biopsy was the future suggestive of lymphoepithelial lymphoma T cell variant. Next one. So we have done a block review. So block review, in the final block review, they gave them down. Okay. So down. Next one. Yeah. So in the final review, they gave the impression of primary conjunctival T cell lymphoproliferative disorder or lymphoma with T follicular helper cell phenotype. This was the final SRL, IHC review, which is done from SRL. So we have done that T cell rearrangement test. So in the T cell rearrangement study, it shows the polyclonal pattern. Up one, before slide. Before slide. Top, before this. Yeah, before this. Before. Yeah. So the polyclonal state, it was the T cell rearrangement. It was a polyclonal. It was not a monoclonal cell. It was a polyclonal. So now coming back to my question, previous slide. Yeah. So how can we proceed with this case? Like whether to take this as a follicular lymphoma, treat as a follicular lymphoma with the T cell phenotype, or it is or we have to treat as a T cell lymphoma. So that is my question to the tumor. Yeah. Yeah, this is the question, sir.
Yeah, so I think you've done a T cell rearrangement studies and your clonality studies are negative, meaning you've not been able to prove monoclonality, right?
Yes, sir. Yes, sir.
Yeah, so in that case, I think you should take it as follicular lymphoma with the T cell phenotype. Yeah, I think we should stick to that diagnosis. See, because very clearly you've not been able to prove the T cell origin. I mean, like as far as T cell lymphoma is concerned. So you'll have to probably take it as a follicular lymphoma with T cell phenotype. That's how I would also look at.
Yes, sir. That's the current plan, sir. We have, sir.
Yeah,
Yeah.
Dr. Arun here. See, the clonality TCR rearrangement was done in a different laboratory and IHC was done in a different laboratory.
No, sir. Both are done from SRL only, sir.
Both are done from SRL. What was the pathologist? Did you discuss with the pathologist? What was their take?
So they have also given the both the opinions, sir. They have given, it can be both the things, but as far as because it's polyclonal, we can take that as a follicular lymphoma. That like that only they told, sir.
So did you rediscuss with them after the T cell rearrangement studies report has come? TCR.
No, sir. Initially, we have discussed, sir. They told that if it is we'll do T cell rearrangement test. If it is a polyclonal, I mean, if it is a we are proving the clonality, we can take that as a T cell lymphoma, like that. They told, sir. After the report, we haven't rediscussed, sir.
Okay. So one thing is, when TCR rearrangement is such a polyclonal, then T cell lymphoma is out. That is one. And I agree with Kripa. Then we are left out to go with the IHC with the T cell phenotype. But I would like to take a second opinion. It's a very rare case. Definitely, it's better to take one second opinion from oncopathologist. But not waiting for the opinion, you can proceed with the treatment as a follicular lymphoma with T cell phenotype. This is my thought process.
I completely agree with Arun sir on that. I think you should do that.
Okay, sir. Thank you, sir.
Thank you. Chandralekha, can we go to the next case?
Good evening, sir.
Yes, Gokul Krishnan, you can present.
Good evening, Arun. Today, my case is a 55-year-old male patient who is diagnosed as carcinoma lung, metastatic carcinoma lung. Patient has a family history of malignancy, no comorbidities. And the tissue biopsy showed histologically it was poorly differentiated squamous cell carcinoma, and IHC also showed it is a squamous cell carcinoma, and the patient is a non-smoker, a non-alcoholic. Patient was started. Next slide. Patient was started on initially started on weekly napacli carbo, then from second cycle 3 weekly napacli and carbo. Patient is now on third cycle, and we have also sent NGS and the PDL1 panel. Next cycle, sorry, next slide, please. Next slide. So this is the IHC. It showed a squamous cell carcinoma of the lung. Next slide. This is the PET CT. Patient has actually pleural deposit with pleural effusion. Next slide. Next slide. Next slide. This is the NGS report. Actually, the NGS report came out EGFR exon 19 deletion. So this is a squamous cell carcinoma patient, a non-smoker. Patient was started on napacli carbo on third cycle now. Now the EGFR, I mean PDL1 negative, and the NGS showed EGFR exon 19 deletion. So my question to the tumor board is, so how to guide the further treatment? Our current plan is to complete the 4th cycle of napacli carbo and do a PET CT to assess the response, and further decide on Jeftinib after the PET CT, sir.
Okay. Why osimertinib you didn't consider? Why Jeftinib is a cost problem or?
Yes, sir. I mean, we haven't considered anything. Just EGFR inhibitors. Actually, I mean, we haven't discussed with the patient yet. after PET CT only we are planning to discuss, sir.
Okay. Fine.
So yeah.
Yes, Kripa.
Yeah. So two things here. One is even in squamous cell carcinomas, around 4% of EGFR positivity has been reported, and this is being published from Tata as well.
Okay.
So that's one thing. The other thing is this could be a mixed component, adenosquamous histology as well, because they have called it a very poorly differentiated as well. So there could be an adeno component or an adenosquamous mixed component, which is why you're getting to see the EGFR exon 19 deletion. And that's the common one that you're getting to see, the variant as well. So having said that, how's the response to therapy up until now? You said 3 cycles are over. How's the patient responding?
Symptomatically, he is better, sir.
Okay. So in
So
that
what
case,
is the VAF here? Sorry to interrupt, Dr. Kupa.
Sure, no problem, please.
What is the VAF here for exon 19 deletion?
So VAF, they...
I mean, is it confident call or on tissue sometimes if it is below VAF? These
Sir, actually, they given VAF as has the, I mean,
No, can you go?
frequency below the limit of detection of this assay that they have given.
No. Can you go? Can you show us that report? I mean, you
Yes,
have
sir,
that.
it was there, sir. Next slide. Here it is. They're given. Zoom.
2.48%.
48%.
Oh, it is quite low for the tissue, sir. And
Because
have they given? If you look at the complete report, maybe we can see it later. If not now, down they would have given the depth of sequencing also. So at this particular position, how many reads they have got, and out of 2.5% means if there are say 100 reads, then there will be just 2.5 reads which are calling out this deletion, right? And
the
for
tumor content is 80%, Dr.
correct,
Surchi.
yes, yeah. So
Correct.
looking at the tumor content, sir, and being VAF at 2.5%, it is very intriguing to believe this result. So probably I would suggest to repeat EGFR if the disease is progressive, and maybe liquid biopsy would also help. However, if tissue is available, I think we should repeat it, sir. I mean, we may not be very confident about it. Yes.
The very, very valid point, Dr. Surchi. I think this is
Yeah,
very important, valid point. Yes.
great. The only thing is, if you look at the particular substitution mutation, the 746750 is one of the most common indels. So it's the most common variant of exon 19 deletion that's been picked up here, number one, albeit at a low VAF, and it is pathogenic in tier 1 as well. So I think that's, and the tumor content is very high, like we've already spoken about. But what is the limit of detection of the assay, LOD? You said that this was detected below.
They given a note there, sir. Actually,
Yeah, you can see EGFR has been detected at a variant allele frequency below the limit of detection.
So it is
Using
below.
alternate testing methods is recommended.
So I think, they themselves have definitely suggested that. So you should definitely look at getting it done because it's below the LOD.
Okay.
I mean, like the limit of detection of the assay. So it makes absolute sense for us to go ahead and get it repeated.
Okay.
But nevertheless, this is one of the most common drivers, and even this particular substitution mutation, 746750, is the most common typical variant that you get to see.
Yeah, right, sir. But when we look at the next generation sequencing assay, sometimes indels are called out as false positive, and on tissue we need to be a little bit more careful because, and I need to know 2.5% means out of how many reads. That would also help. Maybe
Correct.
we can check back with the lab and see that, ask them that how many reads have you observed at this position, and out of how many reads we are looking at 2.5%. Say if there are 500 reads at this position, then 2.5% will mean 25 reads to me, and it is like good enough, right? Or
That's right.
yeah.
So yeah, the depth matters. So I think we should
But
definitely.
Dr. Surchi and Dr. Kripa, see, if they have written that, level of detection is 5% and it's below that 5%, 2.5%, then they should not report it as positive, right? Because that it is based on the platform what they tested and validated. And they cannot report mutation that is as positive when VAF is below the level of detection, right?
Right, sir. Sorry for the disturbance, but I just want to add one point here, sir. It is always a two sides of coin. Okay, if we don't report, we are missing out on a tier 1 pathogenic mutation where
Okay.
the patient may be benefited. But since this is a poorly differentiated squamous cell carcinoma, I think if we are suspecting that, we are just looking at 4% of the cases which are positive for EGFR mutation, and we are we are looking at a low VAF, low confident variant here, then repeat testing would matter. If it would have been lung adenocarcinoma, then I would have advocated in different way that, okay, even a smallest of signal is very important for the patient, and let's look at it in a positive way. So it's always like two sides of a coin. If we
Okay.
don't, yeah.
Yeah, I understand. Okay. So here you suggest liquid biopsy in this, and based on that, take a
No,
call.
I would suggest a repeat tissue.
Repeat tissue biopsy.
If tissue is not possible, then only go for liquid.
Okay. Okay. That makes sense.
And what panel is this? I mean, like, if I might ask, what panel was this? Was it
Actually, in the medgenome, there is a lung cancer NGS panel, is the 18 gene panel, sir.
Oh, so it's a limited panel, 18 gene
Yes,
panel.
sir.
Both DNA and RNA sequencing as well, or? All right. Anyway, whatever it is, yeah, no worries. I think anyway it is below the limit of detection of the particular assay that they have used. So I think definitely, like Dr. Suchi also rightly said, it, yeah,
Yeah,
definitely.
ideally in these cases, the lab should, the expectation is that lab should call and explain such cases, and take a step ahead to probably help out to understand that what is the VAF and what are the reads, and then be very vocal about what they have seen. Because with tissue, in 30% of cases, I do feel that I have to talk to the clinician and tell them that, see, the tissue quality is very poor and I'm not able to get more than these reads, but whatever information is there, this is what it is, and let's think what further can be done. So that is one thing. Maybe the labs, you can ask the labs to get back on with the scientific team to explain the report in much more comprehensive way.
Yeah, true.
That's true. That's true.
So one doubt here, this is Pavitra here. Suruchi ma'am spoke something about doing the re-biopsy and then sending the sample for EGFR, but then the patient is already treated. So would doing a re-biopsy be
No,
accurate?
not re-biopsy. No. If my message was that way, it is not re-biopsy I'm suggesting. Maybe the same tissue. And if tissue is not available, then if the disease is still present in the body, then liquid biopsy might help to reconfirm it.
And
Just
in that
a
way, a
reconfirmation,
PCR
even by PCR.
Yes, okay.
Okay.
Thank you, sir and ma'am. So regarding to consolidate this case, the two things we had discussion point of view. That is, one thing was it was a squamous cell carcinoma, and though it was poorly differentiated, we could have it as an adenosquamous variant, or a squamous variant also can turn to be EGFR positive. And the other thing of discussion was the VAF frequency for this patient, which was 2.4% only, which is considered to be low. And hence, after discussion, we decided to discuss with the oncopathologist there in the thing regarding the VAF and the reads they have seen for this patient, or either consider a repeat panel for this patient. So we'll move on to the next case, sir.
Okay, thank you, ma'am. Okay, so my next case is a 69-year-old male patient. He is a known case of carcinoma pancreas, stage 2 patient. And initially, patient presented with obstructive jaundice, ERCP plus Simpson. Initially, it is operable, but because of the age and other things, patient is not willing, and comorbid patient is not willing for surgery. For now, patient is on neoadjuvant chemotherapy. Next slide, please. Patient is on neoadjuvant chemotherapy with gemcitabine and nab-paclitaxel. Patient has completed 4 cycles. Last cycle on 3rd of February this month. Next slide, please. So these are his pathological report. Ductal adenocarcinoma. Next slide. Next slide. This is PET CT. It is a localized disease. Next slide. Next slide. So we have sent the hereditary cancer gene panel for the patient, and it has came out. There is a gene variant detected that FANCI positive, and it is given as pathogenic. And so our question to the tumor board is, what is the significance of this? This variant, and do we need to do family counseling and testing? Testing the family also for hereditary mutations.
Okay, fine. I will go. See, I think I discussed one case, similar case before. That was a breast cancer case. Similar, almost same. Fanconi's gene was altered. What we know is it is a DNA repair gene. Definitely, it is Fanconi's anemia is autosomal recessive. So we need to check the family history, pedigree tree, genetic counseling. Definitely, it should be done. There is no doubt at all in this case. Apart from that, we will manage the case as any other pancreatic cancer. This particular mutation is not going to change the way we are going to treat. Only one thing is, because it's a DNA repair, probably platinum response may be more. Probably, I don't know how much the data is there. Probably introduce oxaliplatin or folfirinox instead of gem-nab-taxol. Whether it would have benefited the patient more is the only thought that comes to me in this particular case. Otherwise, treatment plan will be the same: genetic counseling and germline testing, and looking for a pedigree chart and see what to be done.
Okay.
Yeah, so I think the other thing is, here also they've mentioned this as an additional finding, and no clinically significant variants have been picked up as far as the final reporting is concerned. So you will probably have to check with them as well, just discuss this report also, and, as to why, why have they called it an additional finding, and, how relevant is this, as far as their reporting standards are concerned, number one. And I agreed with Arun sir on the rest of it. Is there any other family history or anything? Does anyone have an inherited bone marrow failure syndrome in the family?
No, sir. No family history of any inherited bone marrow tumor. No history of any malignancy also in the family, sir.
Okay, and the patient also doesn't have anything.
No, sir. Their blood reports also normal only, sir. No cytopenia.
No cytopenia, nothing. All right, fine.
So I think FANCI carriers have a moderate risk of developing pancreatic adenocarcinoma, and that's why they mentioned it in an additional finding, though he's a heterozygous carrier and not a homozygous.
Is that the reason why they've mentioned it as an additional finding? Because, I'm sure they could have mentioned that as part of their, findings as far as the primary report is concerned. This looks like an addendum or an additional finding.
Makes sense.
So I think they should probably just go ahead and recheck or cross-check with the lab as well, number one. And as far as the treatment is concerned, if you had a good enough response, are you contemplating SBRT or anything like that, given that it's localized disease?
No, sir. Actually, now after PET CT, we planned PET CT, sir. The 4th cycle completed after 2 weeks. We planned for PET CT.
Okay.
Based on PET CT, we will maybe plan, sir, for a SBRT.
Okay, yeah, fair enough. Because if you're not contemplating surgery, I think some sort of local therapy, especially if you've had a decent enough response to your 4 cycles of gem and nab-pacli, then you could look at offering SBRT.
Okay, sir.
That's feasible.
So thank you, sir. So this patient, CA pancreas, locally advanced CA pancreas, who has been reported to have FANCI positive. This is autosomal recessive, basically. So as discussed, we can consider germline testing or genetic counseling for the subsequent family members also. And anything else to add, sir? If I missed it.
Fine, Chandralekha, we can proceed.
Okay, sir. So we'll proceed to the next case presentation, sir.
Good evening, ma'am. Good evening, everyone. Hello.
Yes,
Yes.
you're audible, doctor. You're audible. Please proceed.
Okay, okay. Next slide. Can you open the slide?
Slide is not visible.
Yes.
Just a second, ma'am. Just a second.
Yeah, ma'am. This is the slide. Good evening, all. Today, my case for today is a 70-year-old male. He presented as a metastatic CA lung with liver mets and skeletal mets. Biopsy was done from the livers, which showed a metastatic adenocarcinoma. So, since he had a severe skeletal metastasis and pain, we first started with the palliative radiotherapy to bone mets and empirical gefitinib was started. Next slide, please. Next slide. And denosumab was given. Next slide, I'll come to the clinical questions later. NGS was done. Empirical gefitinib was started and NGS was done. When the palliative radiotherapy was done, we got the NGS report which showed next slide. The report which showed triple mutations. One is EGFR exon 19 deletion, and another one is a PIK3CA mutation and TP53 mutations. PDL1 TPS was 0%. So now, according to this, we have started on pemetrexed plus carboplatin and osimertinib, and denosumab we have given for bone mets. So the clinical question for today is previous slide, please. The prognostic value of PIK3CA mutation in this case, and second line therapeutic implications, and role of concurrent TP53 and PIK3CA in resistance pathway. So, in the presence of PIK3CA mutation, will us giving osimertinib will it help, or it will lead to resistance pathway because cross pathway activation is there. So, how will be the prognosis along with TP53 mutation? Any other drug can we combine with this, or any other newer trials going on in this with these three mutations? If the prognosis happens after this line, what can we do? Sir?
Are you able to hear me? Hello, can you hear me?
Yeah,
Yes, sir. We can hear, sir.
Yeah, so I think, very clearly, like we'd spoken about earlier, these are all co-mutations that can happen.
Okay.
As far as the P53 co-mutation, we know it's prognostic, meaning people who have a P53 co-mutation, we know the biology is aggressive. They tend to have a shorter PFS and also more rapidly progressive disease. So I think that's something, like I said, it's prognostic information. But even if you look at the FLORA2 data, these patients did benefit from OSI plus chemotherapy. So whatever you've done, I think I would agree with your treatment decision of OSI plus chemotherapy. That's the right way to go forward.
Okay.
As far as at progression, what happens? Again, like we'd already discussed about at progression, you will have to look at repeating another biopsy and look at getting a CGP done at that point in time to understand the resistance mechanism at that point in time, and then take a call on your second line therapy. Because you can't do that right away, because we all know that there are different mechanisms: primary resistance mechanism and secondary resistance mechanism. Like,
Yes.
for example, acquiring a meta amplification or meta exon 14 skipping mutations. Again, you can have a T790M mutation, or transformation to small cell, or your other alternate signaling pathways can get amplified. These are all resistance mechanisms. So it'll all boil down to whether it's on target or off target resistance mechanisms. Then we look at targeting the resistance mechanism if there is a targetable resistance mechanism. So I think that's how we should look at approaching it. I think as far as right now is concerned, absolutely justified in going ahead with osimertinib plus chemotherapy. I think I would have done that as well.
Okay, sir. So what about PIK3CA mutations, sir?
Yeah, so again, that's also very, indicates that it's a aggressive biology. Okay. Seeing that it's pretty aggressive, and that's what it denotes. Basically, the presence of P53 co-mutation also tells you the same thing, and the PIK3 also.
Okay. So, role of PIK3 inhibitors alcoholism in second line.
Unfortunately, even in later lines of therapy, it is not yet approved for lung cancer.
Okay, sir.
Absolutely not approved. So again, we're talking about off-label indications,
Okay.
which we can use when we exhaust our standard of care or run out of standard of care options. Until
Okay.
then, we can just go ahead and focus on just targeting the driver mutation or the actionable genomic alteration here, which is EGFR.
Okay, sir.
Yeah, because all the trials, looking at all these EGFR TKIs, did not exclude patients who had a PIK3CA mutation.
Okay, sir.
So that's not an exclusion criteria. So you don't have to really be worried about the PIK3CA. P53, yes, they looked at stratification factor, and they looked at a subgroup analysis of these patients as well. Yeah, Arun sir.
Yeah, see, I totally agree with Kripa. See, even with PEM carbo plus osimertinib, if you see the Flora 2 trial, I think there is a significant difference between the two subsets, P53 negative and P53 positive. Adding, but still going only with osimertinib with it PEM carbo, that's not a good choice. Probably PEM carbo plus osimertinib. That may help. But one thing I was thinking is, what about amivantanab plus lazertinib? Because in P53, I think when co-mutation is there, this particular regimen is slightly better than osimertinib plus chemo, right?
Actually, sir, again, cross-trial comparisons. So interesting. I mean, like we just had a recent discussion as well. So how we look at defining high-risk EGFR? One is, large volume of disease, brain metastasis, high ctDNA load at baseline, and then your co-mutations like your P53. But if you look at all of these subsets, the hazard ratios were pretty similar for both Flora2 as well as for Mariposa. So, which is why, and again, even though we call it technically the chemo-free regimen, the toxicity, as we've already discussed earlier as well, with the Mariposa regimen is not negligible. So, about 35% had treatment discontinuation rates, DVT, 4 months of anticoagulation for the first period, and then 65% had an infusion reaction. Albeit we have, we will have shortly access to subcutaneous amivantamab, but until that happens, even with the skipper strategy and the cocoon strategy, again, skin toxicity, nail toxicity, all of these are concerns. And not to forget, last of all, but certainly not the least, the financial toxicity as well, with lazertinib not yet available in India. So I think, having said all of this, even for P53 co-mutation, when you do a cross-trial comparison between Flora2 vis-a-vis Mariposa, the hazards are pretty similar, and the benefit seems to be the same. So I think, or I feel that Aussie plus chemo is definitely a good enough option here, sir. I don't think we necessarily have to do AMI plus lazertinib here. Probably if this patient had met as well here, then probably yes, I would be tempted to go in with amivantamab in the first line. But no, here there's no met. So yeah, you were saying something. Yeah, please go ahead.
So penetration of brain also well with osimertinib, no, sir, compared to amivantamab with lazertinib.
Yeah, again, the data with CNS metastasis for both the trials as well, both Aussie plus chemo and even with lazertinib. Again, the data is pretty similar. So there's nothing actually to write home about, as far as one being better than the other. All that we know is probably AMI plus lazertinib is better than Aussie alone. That we know. That's the trial. And again, Aussie plus chemo is also better than Aussie alone. So I think it's safe to say that probably Aussie alone is gone out of favor now, and we are already in the era of combination strategies. Which combination? Albeit, I think right now, as far as the sequencing strategy is concerned, I think it's prudent to start off with Aussie chemo, albeit for a lot of reasons, including financial toxicity and not having access to lazertinib as well. And albeit we don't get to see a major advantage, albeit even with those patients who are a very high ctDNA load up front on baseline as well.
So thank you, sir. Thank you, sir. So this is the second patient.
If there is a failure after the osimertinib, what other drugs should be used?
Yeah, so second line is when we would look at using amivantamab.
Okay.
Yeah, so I think that's where I would look at placing the molecule then.
Okay.
And especially, and like I said earlier, I mean, like it will boil down to your resistance mechanism. Absolutely, at that point in time. So do a repeat CGP at that point in time. And if there are no other, resistance mechanism and the patient still has the EGFR, which is driving the disease, absolutely go ahead and offer amivantamab-based regimen, second line.
See, whatever the data we have is definitely in P50 co-mutation, amivantamab plus lasatinib is superior to osimertinib. That data we have. But the data what we don't have is amivantamab plus lasatinib versus
Osi plus-
PEM-carbo plus OC. We don't have that data. So unless that data is available, probably we need to go with probably OC plus chemo. Probably we need to wait.
Okay. Okay, sir.
Okay, sir. Thank you, sir. With PIK3CA mutation, and in this patient, since we have the dominant driver mutation of EGFR positivity, and the patient is also already on chemotherapy, and we have the option of combining osimertinib along with the chemotherapy. Also, we had the discussion of the role of amivantamab and lasatinib. In this scenario, also we had the discussion about it, and the role of TP53 and PIK3CA in this patient as such. Maybe as of now prognostic, and subsequently on progression we can consider CCP at a later point of time. So thank you, sir. So moving on to the next patient. I think that the
Okay, we have done 8 cases.
next
We're
8
done.
cases
Yeah,
done.
I think we are done.
Oh,
We have come to the
okay,
end.
okay, sir. Okay, sir. So that was a really enlightening session. For today, we had a variety of cases, including pancreas, lung, and thank you, sir. Thank you all the doctors in the scientific committee who had given their valuable inputs. Thank you, Arun sir. Thank you, Kripa sir. And thank you, chairpersons, Dr. Suruchi and Ms. Pavitra, for attending this meeting as well. And thank you all the participants who had given their cases and posted it for this very valuable discussion as well. Thank you, sir.
Thank you, Chandralekha. Thank you very much.
Thank you, sir.